Now we're going to finally dial it back into Chapter 13 and talk about exposure factors. Before we took that diversion, we talked about the prime exposure factors being kVp, MA, exposure time, and SID. But focal spot size is an exposure factor, filtration is, generator type is as well. The reason they're not primary is because you should set a specific focal spot for the exam type. Filtration's generally not going to change, and on a given machine, you're not going to be able to change generator type. So, Chapter 13 overview, we're going to talk about patient factors, we're going to talk about tissue thickness, tissue composition, and pathology, and how to adjust our technique for each one of those. Spoiler alert, most of the time it's going to be mass. We're going to talk about image quality factors in optical density, image contrast, and image detail. Remember, we've got two different things in detail. We've got sharpness of recorded detail, and we've got visibility of recorded detail. Image detail is really your sharpness of recorded detail. We're going to talk about technique charts, where we've got fixed technique charts, or fixed kVp technique charts. And as the name implies, the kVp is pretty much set. We're going to talk about variable kVp charts, and as the name implies, the kVp is variable. So the difference between those is what you're doing with mass. So fixed kVp, well, you've got to have variable mass. Variable kVp, the mass is fairly well fixed. And then we've got high kVp charts, and those charts are where we're doing specialty type exposures like barium work. And then we've got automatic exposure techniques and different types of equipment configurations where we truly have things like automatic exposures, automatic exposure where you select the cells, the individual exposure cells that you might be using for a particular exam, or what they call anatomically programmed radiography, is sometimes also referred to as automatically programmed radiography. And that's probably what you're using more than anything else. You push a button on your control panel that says chest x-ray, and it sets your kVp. It sets a specific backup time. It selects your photo cells for you. And that's what those are. APR are those type of machines. So again, your basic exposure factors, kVp, MA, time, so you've got mass and distance. You got generator type, filtration, and you've got what you control with those factors, and that is the quantity and quality of the X-ray beam. So kVp is what the technologist uses to control beam quality. We would say that if your beam did not penetrate through a patient at all, then it could not create an X-ray. And in that way, that X-ray beam, for our purposes of making an X-ray to make a diagnosis, that X-ray beam would be of no quality at all. So if the beam barely penetrated the patient and hardly made an X-ray, then it would still be very low quality. So the X-ray beam quality is tied directly to penetrability. So the X-ray beam, not the X-ray image, but the X-ray beam quality is controlled directly by kVp. The higher the kVp, the higher the beam quality. The more penetrating the beam is, the higher the quality it is. kVp, though, greatly affects quantity as well. So think back to that brim spectrum. As you increase your kVp, if you do nothing else, then you get an increase in peak energy. It determines whether or not you get that characteristic spectrum. But remember, the area under that curved line, that bell-shaped curved line, the entire area under that bubble represents the number of X-rays that you create. So whenever you increase your kVp, the height of that bubble goes up and it pushes towards the high energy side. But the height is what we're talking about here. So you get a 15% increase in kVp in the area, total area under that curve would double. So a doubling, we refer to that as an exponential relationship, because if you doubled your kVp, 15% change in kVp doubled your quantity. So a doubling of kVp would result in a massive change, much more than doubling of the quantity. So kVp, it affects the numbers, and it affects the numbers directly, in that if you increase your kVp, you increase your numbers, but it changes the numbers directly and exponentially. It is the exposure factor that we say controls contrast, and that comes with a caveat. It doesn't control contrast all that much anymore. The computer algorithm is what controls your contrast more than any other thing. But kVp is still testable on the registry as being the exposure factor that you can use as a technologist to affect a change in contrast the most. Very important distinction there. So to put it another way, kVp is what we use to change the quality of the X-ray beam. Beam quality affects image quality. Image quality factors include contrast, density, sharpness of recorded detail, and visibility of that recorded detail. So the beam quality affects your image quality. So it greatly affects the beam quality at the image receptor, and it affects the quality and controls the quality of the beam that is produced. It affects the quality and controls the quality of the beam that's emitted. Now here's the rub, though, is that beam quality increases penetration, but as kVp goes up, as you increase beam quality, you increase penetration. As kVp goes up, you increase both of those things, but what you also increase is the percentage of scatter radiation in the secondary beam. So beam quality and radiographic quality are definitely not the same thing. As beam quality increases, unfortunately, in a lot of cases, you're going to have a decrease in radiographic quality. Beam quality means an increase in beam quality means an increase in kVp. That comes with a decrease in contrast, which is a reduction in radiographic quality. Confusing. So how do we apply it to patient exposure? It depends. You got to pay attention to your test questions. When you increase your kVp, and that's the only thing that you do, you increase the output from the X-ray tube. That does increase the penetration, but you increase numbers exponentially. Numbers are what drive patient dose. So if the numbers drive the patient dose, an increase in kVp with no other changes, just an increase in kVp, causes patient dose to increase. Now if you use your 15% rule to increase your kVp, but reduce your mass so that what you have is a more penetrating X-ray beam, then your patient dose actually goes down. Increase kVp all by itself, patient dose goes up. Increase kVp and reduce mass, patient dose goes down. So increases in kVp whenever you change nothing in the mass, then your patient dose goes up. Excuse me. Your patient dose decreases when kVp is increased using the 15% rule and mass is halved. It increases, patient dose increases when kVp is decreased and mass is doubled, and it decreases when kVp is decreased and mass remains the same. Because of that, this is what happens to the exit beam. kVp affects the quantity transmitted through the patient. Since kVp controls your penetration, then kVp also controls what the remnant beam, the characteristics of the remnant beam, what they're going to be. So if we have penetration without interaction, what's going to affect that more than anything else is kVp. So if we increase kVp, we're going to have more photons that penetrate through the patient without any kind of interaction. So we have a higher energy remnant beam. In addition to that, though, the exiting scatter increases with increased kVp. So we're going to have not only more penetrated X-ray photons, but we're going to have more penetrated scattered photons as well. Decreasing kVp does the opposite in both cases. So if we decrease kVp, we're going to have fewer photons penetrate through the patient and fewer scatter that penetrates through the patient. So the effects on the image receptor, we have more interactions on the image receptor with increased kVp. Again, this is just kVp. We're not changing our mass, but if you increase your kVp without any other changes, what you're going to have are more photons of higher energy striking the image receptor. If you decrease your kVp, it goes in the opposite direction. You're going to have fewer photons of lower energy striking the image receptor. So one more time, it controls the energy level of the X-ray beam. Excuse me. It controls the quality of the X-ray beam. It controls the penetration because, again, a poorly penetrating X-ray beam is useless in creating a diagnostic image. So finally, how does it affect the image? Well, more than any other factor, it affects the image. It's a technical factor we use to control contrast because we can penetrate more types of tissue. It penetrates all tissue types, and the higher the kVp, the more similar that penetration becomes. So if we have an X-ray beam that penetrated all tissue types identically, then we would have no contrast at all. We have to have differential absorption in order to see contrast. If everything was penetrated at the same rate, then we would have no contrast. So the closer we get to equal penetration for every tissue type, the less contrast we have. And since kVp, the higher the kVp that we use, the more penetration we have of all tissue types and they become more similar, then we lose contrast. We have less differential absorption. Differential absorption is what gives us contrast. But with increasing kVp and the penetration of more of those tissue types, we have less differential absorption, so we can't see the contrast on the image. We create more Compton. Compton is the type of scatter and the type of fog that degrades the image more than any other type of scatter radiation. So it does the same thing in appearance of the X-ray image as what over-penetration does. So it decreases the contrast, and you can kind of make a comparison to a foggy day if you're driving to school or to work or around town and it's a very foggy day. It makes it very difficult to see the trees, that cloudy appearance makes everything kind of blend into to where you can't see very well. So you don't see the contrast between the woods and the trees and the road and the grass and all that stuff. Very similar. We have, with kVp and increasing kVp, we have fewer proportionally PEs, and that's proportional to the amount of scattered radiation we create. As kVp goes up, it's very important to understand that because of that brim spectrum and the fact that most of our X-ray photons are low energy, and because when we increase our kVp, we increase numbers so drastically, and the numbers of high energy photons are not as great as the energy of low energy, or the number of low energy photons. It's important to understand that as kVp goes up, we get more interactions of all types. But what we get more of, and that includes photoelectric. We tend to think of photoelectric as going down, but they actually go up. But the photoelectric ratio, or the ratio between photoelectric and Comptons, is such that the Comptons increase faster than the photoelectrics. So in that way, we get a higher percentage of Comptons than what we get photoelectric. So the photoelectric ratio goes down, even though the numbers go up. So we can discuss that in class if that kind of lost you, and I can kind of play with some numbers on the board and hopefully make that better understandable. But you need to understand as kVp goes up, all interactions inside of the patient go up. But what goes down, the reason we say that photoelectrics go down is because we get such an increase in Comptons that it appears that the photoelectrics go down. So secondarily, it controls quantity, but it does so exponentially. And the reason we say secondarily is because we want our primary control of quantity to be mass. So what does all this mean? As we increase kVp, we get a longer grayscale. We get more shades represented, which is a good thing up to a point. You kind of get to a point of diminishing returns whenever contrast gets too low that you can't really differentiate between tissue types, then you've got too low a contrast. You want high contrast, but you don't want it too high either. If it's too black and white, well, you need that dynamic range. You need that bit depth so that you can make a diagnosis and differentiate tissue types. So there's a balance there. So longer scale of contrast means lower contrast. Contrast means difference. So if you have lower contrast, that means you've got a lower difference or less of a difference between tissue types or the appearance of tissue types on the X-ray. So less difference equals lower contrast. It also, we refer to that as higher latitude. This might be a little bit tough to wrap your mind around, but in latitude, just the word latitude, if I said that I'm going to give you a lot of latitude in your answers on test questions, then that would mean that I'm going to give you I'm going to be less rigid in requiring a proper answer, right? So generally speaking, you could say that my test questions are pretty black and white. I don't mean my test questions are black and white, but I mean my answers are black and white. You either got it right or you did not, right? So if I gave latitude, that would mean that I would give more shades of gray. It wouldn't be quite so black and white, right? So in a high kVp technique where you penetrate a lot of tissue types and you get a longer grayscale, we refer to that as more latitude or higher latitude. It gives us as kVp goes up, it gives us a greater exposure to the image receptor. And previously we called that density, and you may hear us refer to it as density once in a while, and it's really kind of a throwback to the what happened whenever we got an increase in exposure to the image receptor in screens and films. There was a direct relationship to how black the image was going to be based on how much radiation exposure the film received. So density and image receptor exposure are the same thing, and we use them interchangeably. But when kVp increases, if mass is not changed, then that image receptor exposure is going to increase. How that's going to manifest itself on your image is you might not see any change in the image itself, but your index number is going to indicate that you've got an overexposure. So if you're working off of a system where as exposure goes up, your index number goes down, if you increase your kVp and you don't do anything with mass, then that index number is going to go down. And again, realistically, what's going to affect the appearance of the image is going to be your computer algorithm, and we call that the lookup table. Lookup table is the computer algorithm for a specific exam, and I'll explain that later in the semester. So I'd mentioned in one of the previous recordings that most of the time that we compensate for tissue types and tissue thickness is most of the time we're going to use change in mass. There are times kVp is appropriate. So kVp changes are warranted when tissue density has increased to the point where photoelectric absorption is going to be too great. So if cortical bone thickness has increased dramatically, if patients develop a condition like osteopetrosis increases the cortical bone, or maybe if you've got a patient with plaster casting, or if they have presence of contrast media, especially barium, then you're going to need to increase kVp to penetrate through those things. They're appropriate with an opposite change in mass when you want radiation dose to change. So if you've got a pregnant patient and you're doing an IVP on a pregnant patient, or you have to do a KUB on a patient, or an AP of the L spine because they were in a car wreck, then what you're going to want to do is increase your kVp and reduce your mass. Same thing with young patients. If you have, I don't know, maybe a 6-year-old that you're doing a KUB on, you might want to increase your kVp and reduce your mass. So it's important, though, that if you're going to increase your kVp and you're wanting to save patient dose, then you have to reduce the mass as well. So how to change it? Well, a 5% change in kVp is the minimum amount that you would change just to affect any kind of difference at all. So we tend to focus on 30% change in mass as the minimum amount of mass that you would want to change to just make a visible difference on the image. And visible difference is really not going to be observed because, again, the computer algorithm is going to change all that. But imagine how much of a change 30% is. It's roughly 1/3, right? So 1/3 of a doubling of the mass gives us a visible difference. 30% of 100% change gives us a visible difference. Now, when you change your kVp by 15%, that also doubles your exposure. So 1/3 of that is 5%. So a 5% change in kVp is going to give you that minimal change. So a change by 15% is going to double or half the exposure. So if you increase your kVp by 15%, that's going to double the exposure. If you decrease by 15%, that's going to half the exposure. So if you're phototiming and you increase your kVp by 15%, then your phototimers, providing they're working properly, should cut your exposure to the image receptor by half. If you decrease your kVp by 15%, then So if you're phototiming and you increase your kVp by 15%, then providing your phototimers working properly, then you should see a reduction in your mass to compensate for the increase in kVp. If you decrease your kVp by 15%, then you should see an increase in mass to compensate for that if you're phototiming. So how to change kVp, part 2, how to change kVp or change kVp by 15% and change your mass to change penetration without changing exposure or index number or the density on the image. So that is truly your 15% rule, or the density maintenance formula. 15% increase in kVp, in order to maintain the same exposure, you would reduce your mass by a factor of 2. If you decrease your kVp by 15%, then you would need to double your mass. So an increase in kVp with a corresponding reduction in mass can be used to help control motion. It should not be used if changing MA in time could accomplish the same thing, though, because you change the imaging characteristics of the X-ray beam. It can be used in portable radiography when MA and time are not separatable, or they're not independent. It can also be used on those same type of machines whenever you can't select MA and time separate from each other, but you can reduce your kVp to increase your mass and use a longer exposure time so that you can get a breathing technique. Just to wrap it up, kVp is your potential energy, and that is the relative positive and negative charges in the X-ray tube, and it controls kinetic energy. It controls the speed of the electrons as they travel from cathode to anode. The speed of the photons don't change, the frequency and wavelength does. The frequency and wavelength determines the energy of the X-ray beam in individual photons. It in the BREM spectrum, it controls the peak energy. It directly affects the average energy. As kVp goes up, the average goes up. It affects the number of photons that we create. So as kVp goes up, we create and we transmit or emit more X-ray photons, and it determines whether or not we get a characteristic photon. The effects on contrast are, in all honesty, minimal, but it is the technical factor that we'll use to control contrast. Effects on patient dose are, as kVp is increased and nothing else has changed, then patient dose goes up. As kVp is decreased and nothing else changes, patient dose goes down. As kVp goes up and mass goes down, then patient dose decreases. As kVp goes down and mass goes up, then patient dose goes up. So whenever you're reading the test questions, make sure that you understand what the question is asking you. If it asks for an increase in kVp and how that affects patient dose, and it doesn't mention mass, don't read mass into the equation. So the effects on the image receptor exposure are pretty much direct. As kVp goes up, we're going to get an increase in exposure to the image receptor. As kVp goes down, we're going to get a decrease.